Hello everyone, I'm Paolo Cardone and I am a PhD candidate at the Coma Science Group and the Giga Doctoral School in the University of Liège. My PhD project has two aims. The first one is to investigate psychedelics, namely psilocybin and ketamine, as a treatment for patients with post-comatose disorder of consciousness. And the second one is to test the link between brain complexity and consciousness. So why are we even looking at the brain complexity, consciousness, and psychedelics? The reason is that according to the most recent frameworks in the neuroscience of consciousness, such as in the integrated information theory and the entropic brain hypothesis, brain complexity is necessary for consciousness. The most extreme position, in fact, is that it is even sufficient for the emergence of consciousness. When we talk about consciousness, what we mean is to have an experience, or to live a phenomenological state. When we refer to the complexity, we say the non-reducible activity of interacting brain region. But let's have a look at a more practical example to understand it. To calculate complexity, we use a technique called transcranial magnetic stimulation combined with electroencephalography, or TMSEG. To do it, we first look at the individual MRI and we choose a brain region to stimulate. Once we decide the region, we set an electromagnetic stimulation to the cortex. We look at the brain activity with the EEG and to the average response to the TMS pulse. We can then calculate the brain complexity based on the average response that we can see here. To stimulate always the same point, we rely on an infrared camera that locates both the head of the participant and the coil. If we have a fully awake subject who is undergoing TMSEG, his brain complexity is high. However, let's now imagine that the same subject falls asleep. This time, his brain complexity is low. This is a reliable finding that we have. When people are experiencing something, for example in normal wakefulness or while dreaming, they have high complexity. On the contrary, when they're experiencing anything, like in a dreamless sleep or in general anesthesia, the complexity is low. These states of low complexity are transient and they can always go back to high complexity. Unless... Patients with a dramatic brain injury can fall into a coma. Coma is a temporary state that does not last more than few weeks. Upon awakening, patients may experience a disorder of consciousness. Patients with disorders of consciousness lack functional use of objects. For example, if you give them a spoon as displayed in the video, they cannot show you how to use it. In the same way, they might not follow simple verbal commands such as squeeze my hand. And in the most severe cases, they are even unresponsive to painful stimulation. Disorder of consciousness can last for several years and have no treatment, leading sometimes to the withdrawing of life-sustaining interventions. These patients have a low complexity, as people when asleep. If we could restore their complexity, they might regain consciousness as well. But how can we? One possibility might come from a class of drugs used for centuries for spiritual purposes, namely psychedelic. Recent investigation has shown that psychedelic as psilocybin or subanesthetic doses of ketamine increase brain complexity in healthy participants. When a person takes psychedelic, the brain complexity is even higher than the one we observe in normal wakefulness. Our protocol involves a double-blind, placebo-controlled crossover design. At first, patients will have a multimodal assessment in an observational phase. Then, they will enter the experimental phase, where they will receive the psychedelic and the placebo in two different sessions. Half of the patients will receive psilocybin, and the other half subanesthetic doses of ketamine. While receiving the drug, patient will undergo a TMSEG session to measure brain complexity and several behavioral assessments to catch new signs of consciousness. After 1 week, patient will redo another session that is identical to the first one, but this time with the placebo. Note that the order of placebo and the psychedelic is random, and it is not known by the experimenter. The day after each session, we will do another behavioral assessment to control for carryover effects. We will follow the patient's health up to a year after the end of the protocol. We expect that after receiving the drug, patients will have a high complexity and show new sense of consciousness. This may include the ability to properly manipulate an object, as bringing the spoon towards the mouth, to execute the command that they're asked to, like in our example, squeeze the hand, or to have a stronger behavioral and emotional response to a painful stimulation. In other words, what we want to do is to use psilocybin and ketamine to treat post-comatose patients with disorder of consciousness. Our hypothesis is that this drug would increase brain complexity and consequently increase their quality of life. These drugs are among the safest that we have, with very few side effects. This project will test the assumption that brain complexity is linked to consciousness. And critically, we will provide a new treatment for one of the most dramatic disorders that modern medicine faces.